Hello, everyone, and thank you for joining us today. April is Parkinson's Awareness Month, and the Focused Ultrasound Foundation has organized today's webinar, as well as one tomorrow, to highlight the latest preclinical and clinical advancements in focused ultrasound for treating Parkinson's. Today, we hear from Dr. Elisa Konofagou, Professor of Biomedical Engineering and Radiology at Columbia University. She will discuss focused ultrasound therapies for Parkinson's disease in preclinical models. Before we get started, just a few technical items. If your connection is lost, please simply log in again through the link you received when you registered. You will receive a link to a recording of the webinar as well. And if you'd like to ask a question, please submit it at any time via the Q&A function at the bottom of your screen. We will collect these questions until the Q&A period at the end of the presentation. And now I'd like to introduce Dr. Elisa Konofagou. Elisa, the floor is yours.
Thank you very much, Jessica, and it gives me great pleasure to be able to show some of the work in preclinical models of Parkinson's disease and how focused ultrasound has been able to make some efforts. And this is leading, of course, to the webinar that's tomorrow to be given by Dr. Lipsman on the clinical studies. So Parkinson's disease affects in its early stages the substantia nigra and the striatum, which sits in the midbrain, as you can see here. But it's not the only neurodegenerative disease. Alzheimer's as well as Huntington disease or ALS also affect specific regions of the brain, and typically deeply seated subcortical regions at the early stages. So overall, the central nervous system diseases are among the 15 leading causes of death. We don't really know the reasons and how the progress is advancing. And there's no currently disease-modifying treatments for Parkinson's disease. The current treatments are symptomatic relief. Also, there are a million or more in the US, 10,000 million worldwide, and then 4% of the PD patients are under the age of 50. And it does put a dent in the healthcare with the medication upwards to 6,000 a year per patient, therapeutic surgery, 100,000 per patient, and so on and so forth. So the idea of getting more widespread technology out there that could be non-invasive and non-ionizing could actually also improve the healthcare costs. So why don't we have currently an efficient method of treatment of Parkinson's as well as other CNS diseases? Part of the problem is the blood-brain barrier, which is basically a structure that separates the vasculature from the surrounding parenchyma. So that means whatever flows in the blood doesn't necessarily diffuse into the regions where it's mostly needed. And that's great when you have a brain that's healthy, because it does prevent it from toxic molecules going into the region surrounding it. But when you have a brain that's unhealthy, such as in the case of Parkinson's, that prevents a lot of the different molecules and drugs to actually permeate through this barrier and be able to treat the neurons, especially, that we're trying to help reverse the neurodegenerative cycle. There's different ways of crossing the blood-brain barrier. The most widely known is actually the tight junction, which composes itself of protein strands that links the endothelial cells that you see here in blocks. But there are ways of permeating it. One of them is through transport proteins that transport glucose, for example, or receptor-mediating transcytosis that transfer the nutritious molecules such as insulin and transferrin. So we want to go from the top to the bottom, and this is only a 10 micron distance, but is an ocean when it comes to drug delivery. We're not alone, of course, other than focused ultrasound. There's other techniques looking at chemically changing the barrier or directly injecting the molecules into the brain itself. And what's available right now, it's either non-targeted and non-invasive, or targeted and invasive. And this is where focused ultrasound comes in. It provides the two advantages of being targeted, so looking at one region in the brain, as we said, deep-seated subcortical region, and non-invasive, so it can go through the skull, through the rest of the brain without changing its underlying properties. So the way we can do that is through these curved apertures and transducers that can be single element or multi-element, as you see here on the right. And similar to an optical lens, it has a geometric focus, and only within that focus we can create different thermal or mechanical effects, or both thermal and mechanical effects. So thermal effects, of course, are what's already in the clinic for the treatment of essential tremors, which is within the umbrella of the Parkinson's pathology. And what I'm going to be talking about to you today will be mainly through the mechanical effects. So we want to use the mechanical effects at the geometric focus, have the engagement of microbubbles that I'm going to talk about in a minute, and then the engagement of these microbubbles would actually engage the endothelial walls and the blood-brain barrier itself and allow the permeation of drug molecules. Very simply, the way we do it in mice, which is basically the main preclinical model I'm going to be talking about today, followed by non-human primates, will be to shave only the fur of the mouse on the top of its head. Then we take the transducer here, again, the curved transducer with the geometric focus. We target within a region of the brain, in this case, the striatum. And then we IV inject or intravenously inject these microbubbles that are FDA-approved contrast agents for cardiac ultrasound in the US, and then tumor imaging in the rest of the world. And as I said, those bubbles get engaged after the ultrasound is on. And then to look at the blood-brain barrier opening that ensues, we can inject contrast agents and/or drugs, which we want to use to permeate through the barrier and treat the underlying disease. So this is an animation where it shows the blood vessel, the red blood cells, the microbubbles in white. What you see vertically oscillating is the actual ultrasound beam. You can see that the engagement on the endothelial cells and overall blood-brain barrier that's loosened up. So you can see this from the opening. And as it loosens up from the engagement of the ultrasound beam, the actual molecules that you see here in purple can reach finally the destination, which in the case of neurodegenerative disease is the neuron. As I said, we can use contrast such as gadolinium that normally does not permeate the blood-brain barrier, but as soon as we open the barrier, we can see where we opened it. And these are a couple of examples. On the left, you see the 2D image in the mouse brain, where we open the two regions I'm going to be talking about today, which is the substantia nigra towards the inferior part of the brain, and the corticothamon on the superior part of the brain. These are the two ends of the dopaminergic neuron that degenerates during the course of the Parkinson's disease. This is a 3D rendering in the middle of the two openings, which is the brighter orange regions. And the rest of the brain is intact, especially the right hemisphere. And we also use T2-weighted T2 star images to look at whether we have induced edema or hemorrhage. And I'm not going to be talking much about safety, but we've done a lot, us and others, we've done a lot of work in identifying the range of pressures that are safe in the brain. And we can actually see here, for example, that there's no edema in the two regions that we opened. They have a similar signal amplitude in a T2. Another way to see that is as well as the pressure that we can control to open the barrier. So you can go from the top left where there's no opening. So you can see that there's a uniform distribution of this orange amplitude here for the 3D MRI rendered. And in blue, you see the permeability of the barrier, which is similar across the parenchyma, except maybe for the ventricles and some arteries in the middle. And then as you increase the pressure, and these are all pressures that we have identified as relatively safe in the brain, that means that the barrier does reinstate itself after a couple of days following the opening. You can see that you can go with a small opening in the hippocampus on the right hemisphere when you use 1 to 2 micron microbubbles, and then you can bubble amplitude, you can sort them, and then you can have even higher permeability, very focused in the region that you need it. In this case was the hippocampus for Alzheimer's disease, but as I showed earlier, we can also do this in caudate putamen and substantia nigra, which are relevant to Parkinson's. So gadolinium doesn't treat Parkinson's or any other disease, although it allows us to identify the region where we opened. And we have to go with several orders of magnitude larger molecules to be able to treat. So we've looked at the different molecular sizes that can go through the focused ultrasound-induced blood-brain barrier opening, and the range from the 70 kilodaltons, which is on the order of what proteins that I'm going to be talking about today, neurotrophic factors that help the actual neuro regenerate. 500 kilodaltons, also talking about this today with antibodies that we can reduce alpha-synuclein. And then gene delivery vectors, which basically transduce the neurons to express those proteins. Those are adeno-associated vectors, and those are on the order of megadaltons, so much larger than proteins or antibodies. And we can also deliver them. This is something that we published a few years back, where we can change the pressure on the bottom, and we can increase the actual dose of these compounds as the molecular size increases. So why are we here? We're here to treat Parkinson's, of course, and this is a DTI, or diffusion tensor imaging rendering of the actual brain of the mouse. What you see here in orange is the dopaminergic neuron. It's a large neuron. It starts from the bottom, the substantia nigra that I mentioned earlier. It has the cell bodies, dendrites, axons that go upwards and project into the caudate putamen. What happens is that this dopaminergic neuron is deteriorating during the course of the actual part of the actual disease, and of course we want to reverse it. So to reverse the degeneration of the neurons, you have to go into molecular pathways, and I'm going to just give you a glance of what is the pathway that we want to reverse here. The good news is that we have neurotrophic factors in our brain naturally. We make those in the healthy brain, is actually making those neurotrophic factors. So there is the underlying machine in the neuronal cell that knows what to do with those proteins. So one of them is called the GDNF, glial-derived neurotrophic factor, that binds onto the RET receptor on the membrane of the dopaminergic neuron. And then for it to maintain itself and make sure that it regenerates and restores itself, it has to go to the underlying pathway through what's called the ERK1/2 protein kinase, and then finally to the nucleus that has a transcription factor that can actually get the neuron to maintain the actual status of regeneration. So we want to make sure that we can have the neurotrophic factor go through the actual barrier, bind to the protein, to the receptor, I'm sorry, and then trigger this pathway. Neurotrophic factors are in abundance. We have the BDNF, another neurotrophic factor, very similar molecular size, brain-derived neurotrophic factor, neutrin, CDNF, and so on and so forth. They all go through this receptor, and they go through different pathways depending, but mainly the MAPK and the CREB pathway is the one we want to affect. Gene delivery is also the one, as I said, that transduces the cell and expresses the actual neurotrophic factors. I'm going to be talking about both of them. This is a very long history of Parkinson's disease through direct injection. I don't have time to go through this, but we're borrowing through what's known in Parkinson's and actually some of the failures, especially of the most recent one being gene delivery, and mainly because of the blood-brain barrier problems. We have published this in the past. Can we actually trigger this pathway? And the short answer to that is yes. This is how we can increase relative to the contralateral side of the brain. It can go upwards to 200%. So the red receptor does get triggered with the actual pathway all the way to the CREB, where in the nucleus it can make the actual neurotrophic factor. In this case, we use neutrin, which is a derive of GDNF. So we're not alone, and I'm gonna mainly be talking about our group's work so far, but the foundation has also funded several groups worldwide. Some of the preclinical models that are used are different from the one I'm going to be showing today, but all of them have relevance to Parkinson's disease. This is the Keane et al. Work at the National Research Council of Canada, and they've been able also to open the blood-brain barrier here in the striatum. You see a coronal slide of the actual mouse MRI, so you can see the gadolinium enhancement here. And they were able to deliver CDNF. You can see this as a magnified area in the striatum as well. And the staining here in brown shows you where the CDNF has been able to successfully being delivered through the open barrier. The group in University of Virginia, headed by Richard Price, has done a lot of work, mainly with nanoparticle delivery, and has shown that through systemic intravenous delivery, they can maintain stability over a 24-hour period. The actual BPN nanoparticle enhances larger regions where the actual opening is, and the transgene expression is affected over a larger region with a plasmid DNA encoded for GDNF. So there's an advantage using also nanoparticle delivery with the MR-guided focused ultrasound. Of course, just delivery alone, as we said, is not necessarily enough. We have to trigger the right pathway. They have shown that through the GDNF increase, followed with the focused ultrasound alone, you get a much more significant delivery over the other sham groups and FUS alone or drug alone. And they were also able to substantially increase the delivery of dopamine into the tissue itself. More importantly, through the nanoparticle delivery and the GDNF, they were able to restore the dopaminergic neurons that was lasting on week 6 and week 12 in the deoxy dopamine model that relates to the late stage of Parkinson's disease. So that's with the nanoparticle or the neurotrophic factor. And as I said, we can also deliver the AAV, the adeno-associated vector itself, that is using the neuronal cell to ideally make the actual neurotrophic factor. So the actual idea behind vectors versus neurotrophic delivery is to use the vectors and change the actual genome in the neuron so that it can reverse all at once and for all the actual neurotrophic function. So to make its own neurotrophic factor. So there's a lot of excitement behind gene delivery versus protein delivery, where the idea would be to administer the delivery over relative frequent intervals of time on the order of months. So gene therapies also have been around for a long, long time, and they have been limited by safety and storage capacity mainly. There's a lot of interest more recently, given that they have found that it is safe under specific dosages. We have and others shown that focused ultrasound can deliver adeno-associated vectors, as I said before, even though the sizes are on the order of several orders of magnitude higher than the gadolinium or the proteins itself. And we have shown also that it can be a promising therapeutic. So Kaplan et al. Have shown that you can have dual constructs for cell-specific delivery. You can also use non-viral therapeutics, and I'm not going to be talking about today, but other people, especially with the University of Virginia, have combined it with the nanoparticles that I showed in the previous slide. And Artenga also and SRI have shown that the microbubbles can be also used as the carrier of the gene therapy itself. So this is one example of the work of Kaplan et al., where they've shown that you can have neuroprotection of the dopaminergic pathway, so the actual neuron can start producing the neurotrophic factor before the actual insult. And they've shown that you can have both, again, opening in substantia nigra and the striatum, and be able to have expressed the green fluorescent protein and the M-cherry within the region that was opened. So, so I want to also talk about another one of the Parkinson's disease models that we have been using, and something that has in common through all the preclinical models is that, again, they're trying to assess and portray some of the disease, the human disease, that's characterized by tremors, rigidity, slowness of motion. And again, one of the common denominators across all of them is that it's manifested by depleting the dopaminergic neurons. And the previous model that I mentioned, the hydroxydopamine models, those are the ones that are in the late stages of disease. And what you see on the right is how the dopaminergic neuron gets depleted. And I'll show that also in the next slide. So that's called the dying back process, where we have this pronounced degeneration of the nerve terminals. So those are the ones that are found in the striatum. And the model that we have used is called the MPTP model, and this is the actual formula. Is a neurotoxin that uses metabolites that are depleted in the dopaminergic neuron, and it mimics Parkinson's disease following the systemic administration. So if you use it in a subacute dose, so not acute, but in a lower dose, it actually mimics also the early stage Parkinson's disease that has the partial depletion of the dopaminergic neuron. So it compromises the dopaminergic pathway by lesioning, and it has a dose-dependent regime. Again, varying the dose can get you early to late stages of the disease mimicked as far as the human disease goes. So how does it happen here at the subacute dose that I'm going to be talking about as part of our work? It depletes the terminals at 40%, the axons at 33%, and the dendrites at 22%. So we're trying to see how much of what the actual dopaminergic neuron that we're losing through this subacute preclinical model is getting restored. So can we restore the dendrites? Can we restore the axons, the terminals, and by how much? So the work that we've been doing over the years includes the MPTP model that I mentioned in the subacute phase. We let it degenerate the dopaminergic neuron over 3 weeks. Then we opened the blood-brain barrier on the 1-minute sonication with macrobubbles, as I mentioned before. We use MRI to look at the actual opening of the blood-brain barrier. And then we also infuse the neutron in this case, which is, again, a neurotrophic factor that lets the neuron restore itself. We give it an interval of 2 weeks, and then we repeat the actual administration 3 times or 1 time. So there's no repetition, or we do it over 3 different sessions. And we let the actual neuron restore, and we use a tyrosine hydroxylase, which allows us to see which part of the neuron survived the actual toxin. The setup is shown here, where we have the mouse under anesthesia, the curved transducer, a single element at 1.5 megahertz. We also use a passive cavitation detector that I mentioned earlier, allows us to see what kind of bubble activity we engage and how big our opening is. And also MRI, you see here on the right, similar to what I showed before, shows us the 2 openings in yellow here in the substantia nigra and the caudate putamen. So 2 sonications in 2 different regions of the brain. We target the striatum on the left, and in the midbrain, the substantia nigra, where you see here on in brown, the cell bodies in the very dark brown, and the dendrites that are infusing the actual substantia nigra as part of the dendritic fibers. So we're looking at that to see how much of that has survived the actual toxin, as I mentioned, and we have single treatments and multiple treatments. What you see here as pluses are the actual MPTP administered, and we have the left hemisphere targeted versus the right hemisphere. And when we have the single session that you see here as one red cross, we see some partial restoration, so darker staining on the left versus the right hemisphere. But when you have the 3 sessions that I mentioned, so 3 repeated weekly sessions of the focused ultrasound opening together with the nutrient delivery, we see a higher enhancement, especially in the substantia nigra pars reticulata, where the actual fibers are dendrites relative to the right hemisphere. So of course, we quantified all that in case you couldn't see it, especially on a small slide. And we saw that the cell body count ratio in the substantia nigra increases significantly with the 3 sessions, but does not increase relative to the no focus ultrasound or drug delivered, but MPTP, of course, delivered in none other of the groups of mice. So the focus ultrasound alone doesn't cut it. The nutrient single delivery also doesn't cut it. And the focus ultrasound 3 times opening without nutrient also does not reverse the actual cell body reduction, only the 3 sessions. However, in the fiber density, so the actual dendritic fiber density does change with a single opening and delivery of the nutrient. And very similar, in fact, to the actual triple session delivery of the nutrient. We see here confocal microscopy of these neuronal fiber, dendritic fibers. What we have here is the longer the fiber, the more the actual dendrites have been properly restored. And you can see that on the sonicated side, relative to the non-sonicated, we have restored the fibers in green. It's a little bit of a dark picture here, but hopefully you can see it from the cell bodies in the substantia nigra, we're able to actually restore the neurons relative to what has been happening with the MPTP that has decreased the actual axonal length. And these are some more staining images of what happens with the single session on the leftmost panel and the triple session on the rightmost panel. And although the single session of opening in the caudate now, so this is where the terminals are, has improved overall relative to the right hemisphere, is much less in the left hemisphere than the triple session that has restored the terminals in a much more significant and pronounced way relative to the contralateral hemisphere. And when we quantify that across different mice, we also saw what we saw qualitatively, that the terminal density is requiring the triple session of the openings, weekly session of the openings, and administration of the neurotrophic factor for the restoration of the neuronal terminals. So for this part of the protein delivery for the dopaminergic neuron restoration, we have found that you can have 20 to 22% in the midbrain with both single and multiple treatments restored, and up to 50% in the striatum only with multiple treatments alone. So overall, the repeated focused ultrasound facilitated drug delivery can ameliorate the dopaminergic depletion in the early stages of Parkinson's disease. And of course, if, the idea being that if you have multiple weekly sessions, we can actually restore the entire dopaminergic neuron. And this is something that we are looking at more closely over the upcoming months. The second part that I want to talk about is also what I mentioned with other groups also looking at, is using the actual neuron to be able to restore itself, and using the actual neuron as the machine that it is, So in this case, we can develop the genome of the neurotrophic factor, have it being expressed. This is some of the work that we did a few years back, where we actually did not have the neuron express anything neurotrophic, but it made for the green fluorescent protein. And we can see that the neuron in here is turning to green, and you can see the dendrites from the cell body as a result of the actual expression. And through the use of a promoter called synapsin, we could actually target neurons alone. And again, as I said, the gene delivery, one of the Achilles heels of the gene delivery is that it can transduce the same genome in other cells. Through engineering its promoter, we can actually have most of the time, 95% of the time, expressed in neurons alone, as you see here, co-localized in the image on the right. So for one of the studies that we did was to deliver the AAV, adeno-associated vector, that expressed GDNF into the caudate putamen and substantia nigra, very similar to what we did with the protein in the previous study, and to see whether we can induce neuroprotection. So in this case, we did 2 focused ultrasound sonications, 2 different regions, single sonications, looked at the openings with MRI, and then followed by the actual MPTP 4 weeks later, we will see whether there was any of the neuron that was restored. And we found that after the insult, we could see only, again, the focused ultrasound with the viral vector delivered could have some of the areas where we have the opening restored. None of the other groups had any significant restoration, either with the ultrasound alone or with the AAV alone. That was for neuroprotection, so we can have the neuron protect itself, projecting into the future, should it be exposed to this Parkinson's disease toxin. In the case where we can have a more relevant, the clinical world is where we need to restore the neuron after the Parkinson's disease onset. In this case, it's called the Neurorestoration, similar to what we did with the protein delivery. So we have the dosing first, a single session of the ultrasound opening, survival period up to 18 weeks. And then we're looking at the expression of the viral vector. And here you see that because of the green fluorescent protein that I mentioned earlier, you can see both the cell bodies and the dendrites that project into the part of the substantia nigra region are much more pronounced relative to the viral vector alone delivered through the intact blood-brain barrier on the contralateral side. This is, of course, significant. And we have seen a very similar region, very similar to what I showed you for the protein delivery, also in the caudate putamen, in the neuronal terminals. We also have an increase in those in that region of the terminals being restored. Now, one of the questions that we get typically is what happens to these neurons that look very nice on the actual staining? Does it actually have the neuronal function? Of course, this is the dopaminergic function, so we're looking for the dopamine release. In order to see whether the neuronal function is reinstated, we administer amphetamine that enhances the dopamine release. And because we only had the left hemisphere where it was delivered, then we would have an enhanced rotation of the mouse towards clockwise or contralaterally to where we opened. Before treatment, we had all these groups controlled, AAV alone and focused ultrasound, and with the AAV and without, and we saw no difference. When we did have the mouse after 3 months, and we tested again in an open field test, whether there was any difference, we could see that the mouse was going mainly clockwise, and significantly only the group that was treated with the BBB opening and the adeno-associated viral vector. So the actual dopaminergic activity was enhanced. We had a paper last year that made a cover of Journal of Controlled Release and cover story. And this is a schematic that Marilena Karakatsani put very nicely together that pretty much summarizes the entire study gene delivery and protein delivery in the sub-acute MPTP preclinical model, where we see that the best case scenario is where 50% of the terminals with a triple session nutrient delivery can be induced, and also 76% of the dendritic fiber density could be increased, so very close to what happens before the insult with the glia-derived neurotrophic AAV adeno-associated viral vector. So overall, with a single session AAV, we can have very good restoration of the terminal already, and the triple protein delivery also does the best in the terminal density. I'm going to accelerate the pace in the last 10 minutes that I have to show you a little bit more of what we can do with different routes, and also what we can do in the non-human primates, and leaving some ideas later on with focused ultrasound alone as a device, no microbubbles and no drugs. So something that we looked at also more recently, given that we want to save the amount of drug delivered to the mouse, will be to administer that intranasally. And we have shown that we can deliver, in this case, the dextran on the order of 70 kilodaltons very well into the caudate putamen, very similar to what happens intravenously that you see in the bottom panel. When we did the neurotrophic delivery with BDNF, we were also getting pronounced regions, especially in the substantia nigra, where we had the fiber density increase relative to the contralateral side, both in the substantia nigra and also in the terminals themselves. Another preclinical model that I want to talk about, which is much more relevant to the actual human model, so the MPTP and the hydroxydopamine models have received some criticism because they don't necessarily have the alpha-synuclein bodies that is the pathology or the phenotype that is shown quite a bit in the case of human disease. One of the models that we've used more recently is called the alpha-synuclein model, which also depletes the dopaminergic neurons, but also has these alpha-synuclein or Lewy bodies that are cumulative in the actual brain. The blood-brain barrier decreases the drug delivery efficiency with other approaches that have been previously used to reduce alpha-synuclein, and you need a high dose to be able to have an efficient treatment. So the model that we've used in the mice is the alpha-synuclein model, the A30P and the A53T. Both of them show pathology at 9 months, and alpha-synuclein is accumulated, and we were looking at neuroprotection, where we can have some kind of a degeneration over the course of time. Now, I'm not going to show you these results today, but so far we were able to use the alpha-synuclein antibody that's on the order of 150 kilodaltons. And so in between the proteins and the gene delivery vectors that I showed before in terms of molecular size, and we could see very similar to the GFP, we could express it, we could deliver it mainly in the focused ultrasound BBB opening region relative to the contralateral with significant difference. And what we saw in the actual reduction in the alpha-synuclein model is that when we administer the antibody itself, we could see both in the right hemisphere and the left hemisphere. So remember that only the left hemisphere was opened, we had the blood-brain barrier opened. We could see the reduction relative to the control of the alpha-synuclein in both. So some of what happens in the antibody is the alpha-synuclein antibody does permeate, we believe, the barrier. Despite its size, it has potentially some other diffusion properties that are different from what we studied so far with the neurotrophic factors and the gene delivery. But we did get an enhancement of that effect in the region of the BBB opened region. So we had a substantial difference in the antibody reduction of the alpha-synuclein. The neurons themselves were left intact, and you can see that you have in the co-localized regions, the actual alpha-synuclein is reduced between neurons as opposed to the control region. So this is what I wanted to talk about as far as the blood-brain barrier drug delivery is concerned in mice. Some of the segue here for tomorrow is how this translates to the large animals and also to humans. So if we reduce the actual frequency that I said before, we had 1.5 megahertz to on the orders of 0.5 megahertz or even 0.2 megahertz, we can penetrate with much thicker skull in primates, and we can still focus even with a single element transducer. Here is a simulation. We'll be able to align the focal region with the longer dimension of the hippocampus in this case. And what you see in red is where the blood-brain barrier opening is mainly focused. And this is an actual MRI where you see in orange, very similar to what I showed you in the mice, but now you can see the entire brain and skull of the primate. We can have a very localized region where the opening can occur in primates, in the striatum. And then we've done more recently, as a segue to the clinical trials, we have looked at the acute phase and the chronic phase for what happens in the primates as it relates to potential damage. And we have looked at two different pressures, much lower than the actual mice, because we also have lower frequencies on the order of 0.2 megahertz. And we were able to see that both in the acute phase and the chronic phase, the acute phase is 2 days after opening, and chronic phase 18 days after opening, both at low pressures on the left hemisphere and high pressures on the right hemisphere. Where we opened the MRI on the right of each panel, we had no gross pathology or histology damage. So we have built a clinical navigator system that allows you to use infrared cameras and fiducial markers on the subject's face and transducer to register the beam that you see here on the right relative to the MRI. We can do pre-planning with the simulations that I showed you earlier. We can monitor the cavitation events, so this is where the bubble activity is actually happening, and assess this afterwards with MRI. This is what our system looks like, and we don't have ready to go for Parkinson's disease, but we did receive another one recently that will have us carry this for Parkinson's, hopefully in 3 years or so. And currently we have it ready to go, but interrupted by COVID more recently for early Alzheimer's patients. We have an ID approved, an IRB approved, and the foundation is helping us also get this off the ground. In the 3 or 4 minutes remaining, I want to mention something that other people also have been looking at. So focused ultrasound is mainly a device, and this is actually how the FDA looked at our device and others' devices more recently. So we wanted to see whether there's anything at all that we can do without the microbubbles and without the drugs that I mentioned earlier. So of course, this is not an easy task. The brain is very complex, and it all depends where you're actually targeting. But what I wanted to show you is what we have been doing over the past few years, more recently than what I showed you earlier, is that we can actually induce some motor responses. And of course, in the case of ultrasound and treatment of Parkinson's, we want to reduce these motor responses, but we're definitely tapping into the motor control of the brain. And what you saw here in a movie, and I play it again, is like some small twitches of the actual paw here in the mouse when we go contralaterally, in this case, in the visual area of the cerebral cortex. So we've shown in mice that we can actually tap, when we focus the ultrasound into the motor or somatosensory cortex, we can tap into some motor function. And then when we go a little bit deeper into the brain, we can tap into sensory function. So both of them are actually involved in Parkinson's. The first one, the motor responses, are early stage Parkinson's, and of course in the later stage Parkinson's, there's much more involved than just motor control problems. And of course, this has a lot of applications in controlling both. So this is just by targeting a focused ultrasound in the brain, but we can also target it on the nerves itself. So what we've done more recently is trying to see whether the focused ultrasound can control electrical stimulation. So you see here, electrical stimulation is driving the nerve, in this case, the sciatic nerve that drives the downstream, the muscle, the thigh muscle in the mice. And we're able to see that we can enhance, in this case, some of the actual motor control when we have specific parameters in the ultrasound, especially in the post-repetition frequency. If we change that frequency that you see here at the bottom, we can go from excitation that I showed you in the previous video to inhibition. So we can suppress that activity. And in fact, this relates now with thermal effects. So as we increase the actual underlying temperature, and as the pulse repetition frequency changes from 1 Hertz for excitation all the way to 500 Hertz, we can actually reduce and suppress that activity. And we have seen that we can do that within a safe range up to about 100 Hertz. And what I'm showing you here are some electromyography curves that you see here, from going from blue to red is where the suppression happens through a slight increase upwards to 10 degrees C of the actual nerve. This also translates to humans. This is the last part I'm going to talk about. And we have been trying to also suppress some of the electrical stimulation on the nerve, the median nerve now, that innervates the fingers, thumb and index especially, and trying to suppress that through the focused ultrasound. In this case, we do both electromyography and EEG with a simple, in this case, EEG with 4 electrodes. And very similar to what happens in the mice, we want to modulate this activity through that's mainly electrically stimulated. And we can also image that. So we can actually image the activity through a separate imaging transducer. We can see where the nerve is, and then the activity in the red as the ultrasound is turned on. So the motor response does get modulated with a focused ultrasound. In this case, it is an enhancement because we went with very, very low PRFs, this is in normal volunteers. But we believe we can do something similar to the mice, suppress that. And then the somatosensory evoked potential was also suppressed in the EEG measurement, so that we can also modulate some of the somatosensory function as well as motor function. So in conclusion, I've tried to take you on a journey of what has been done from preclinical and with some clinical applications at the end. We're able to restore the dendritic sites of the substantia nigra with both single and triple sessions of administration of the protein through the open blood-brain barrier. We can restore the cell somos and the terminal sites only with a triple session for the protein delivery, but with a single session of the adeno-associated viral delivery. Some of the functionality in the neuron can actually also be restored up to 72% for the dopaminergic terminals. And also 3 months later, we actually saw the dopaminergic neuron being more functional after administration of amphetamine. In the case of alpha-synuclein model, we can increase the antibody delivery up to 3 times. In the case of modulation alone, so no opening of the barrier or macrobubble administration or drugs, both in the central nervous system and peripheral nervous system with the median nerve and sciatic nerve, we can use focused ultrasound alone to modulate some of the electrical excitation that we hope that also could translate to Parkinson's disease. We have a lot of work to do, us and everybody else, on preclinical models and also clinical studies that are going to be shown tomorrow. We want to see how long these effects last for the neuronal functionality. We want to quantify also the dopamine levels and see whether how they also last and by how much they're increased. And of course, translate this to Parkinson's disease, most likely for the early onset, where mainly the motor control is compromised, both with blood-brain barrier opening and in the first stage with the adeno-associated gene delivery, as we saw that this has the highest restoration rate with a single session. I want to thank all the sponsors here and of course the foundation for funding us throughout all the studies that I just showed. The people here in my lab and shown here pre-COVID on the High Line of New York. We hope to get back to it soon. And the people here who are bolded names are the ones that have contributed to the work that I showed and shared with you today. Thank you.
Thank you, Elisa. That was really great. So we have several questions, and I encourage you all to keep sending your questions. If you have them, we'll try to get to as many as we can. So first off, what are some of the risks associated with opening the blood-brain barrier?
So there are, of course, risks, and it's all the benefit to risk ratio. We will not open the barrier. We will not need to open it. So as I said in the beginning, the barrier should be intact in a healthy brain so that it can keep all the toxic substances that are naturally circulating in these in the blood vessels. However, what we've seen over the course of 15 years that we've been doing this work with multiple sonications in both mice, but especially in non-human primates, because we don't sacrifice our non-human primates, we keep them for behavioral studies that I didn't have time to show here, is that through behavior and also through pathology, when we actually did look at histology and pathology, we have seen that the barrier does not actually have any deleterious events into the brain when it opens. So we open it slightly, as I said, so enough for the actual drugs to go through, but not necessarily for larger molecules that could be toxic. We haven't seen any adverse events in our monkeys, even after survival. We don't place them in a sterile environment, and they still don't have any behavioral changes or dietary changes or any of that sort. In fact, if anything, we have seen an enhancement, as you probably, if you know our literature, we have published on that, that there is an enhancement in cognition as a result of the berry opening. There's a lot of other studies that our group and others have extensively published on this, on the berry opening safety. And of course, the pressure range is very important. So it's very important to say that there is this window, safety window, that you have to operate under. And if you operate under that window, the barrier is safely opened.
Great. So we have a question about the choice of animal models. What is the reason that we use very small models like mice and very complicated non-human primates? Is there not an intermediate model to utilize?
So this is, I'm not an expert in this field, but from what I understand, it's a very difficult model to develop in large animals. In fact, we've looked at, and we're going to be looking at this more in developing MPTP model in monkeys. And this is notoriously difficult. We're actually going to partner with a couple of different groups across the world. This is because the monkeys become very unhealthy, and it's not just the motor suppression, it's also you know, the dietary changes and some vital signs are changed. So it's very detrimental when it comes to larger animals. I'm not aware of any other larger animals that they've tried Parkinson's disease models on. Typically, people use NHP or mice or rats.
Okay, and regarding what you've shown, you've been able to reverse motor symptoms of Parkinson's. Do you think this treatment could also reverse cognitive symptoms?
Yes, we believe that we can, well, we haven't really looked at that yet, but that's something that we have to use the right drugs for that, pharmacological agents that could enhance some of the cognitive behavior. As I said before, we have seen that the blood-brain barrier opening alone could actually have some enhancement of cognition. So what we have seen is that in mice, we can improve some of the working memory. In non-human primates, we're able to improve the target accuracy. So this is on a touch panel where the monkey is asked to so the target accuracy is slightly increased with just the opening alone, and also the speed by which it actually touches the target. So that's called the reaction time. So there are some motor improvements, but also cognitive improvements with the opening alone. With the right drugs, we can also enhance some other cognition. Of course, that remains to be seen.
Have any studies examined whether focused ultrasound can modulate neuronal activity where the BBB is being opened?
Other studies than what we have done?
Yeah, so I guess, yeah, so maybe that's already been clarified. Can you say what the limit on the size of particles that can be delivered is?
Yeah, that's a very good question. We know that we cannot get our macrobubbles through, so that's on the order of microns. So we shouldn't be able to do microns. So on the order of size, we have seen that through our work, I talked about molecular size on the order of 2 megadaltons. Those AAV vectors are on the order of 4 megadaltons. That amounts to about 20 to 30 nanometers, and I believe some other groups have shown that we can go upwards to 100 nanometers. So that is the upper limit. We haven't done work on the upper limit. We were looking at the lower limit, which we can actually control through the pressure. So exactly one thing that translates intuitively is that the blood-brain barrier is like a door, so you can actually can nudge it open a little bit with a little bit of pressure and get, for example, gadolinium through, but not the other molecules. And then you can nudge it even more and prop it more open for larger molecules. But by how much it can open in its full range safely, because we're of course trying to do this safely, we currently don't know.
Okay. And is the cavitation mapping that you do able to predict off-target BBB opening in regions outside of your desired focus?
That's a very good question. We have not looked at off-target opening with blood-brain barrier. Actually, I take this back. Yes, we can. Something that we've seen in non-human primates, not in mice, is that the cavitation happens in cortical regions, especially under the skull. So when you have the highest reflections, when you cross the skull into the brain, there is what's called an impedance mismatch. So you can get a reflection back to the transducer of the ultrasound, and that enhances the pressure that's felt at the microbubble. So you do get an offsite potential blood-brain barrier opening in some cortical regions, and that depends, of course, on your beam angle related to the skull, the depth of the focusing. But we have seen when we do get enhancement of the MRI, it does correlate with the maps that we have for off-targeting.
Okay, well, thank you, Elisa. Unfortunately, we're at the end of our time, so this concludes our webinar today. I apologize, we did not have time to address all of the questions. If your question was not answered, or if you'd like more information, please visit our website, fussfoundation.org, or email us at info@fussfoundation.org. And thank you all for joining us today, and please stay tuned to our newsletter and website for additional information about future webinars. And I encourage you all to join us again tomorrow at 11:30 a.m. Eastern to hear Dr. Nir Lipsman discuss the latest clinical advancements in focused ultrasound for treating Parkinson's. You'll find the link to register for tomorrow's webinar in the same email that you received for this one today. So again, thank you so much, Elisa, for this, for being with us, and this was really great. Have a great day, everyone.